This is our newest episode of the Lebanese Physicians Podcast, and today we will be discussing our topic actually is understanding adolescent suicide risks in Lebanon. And my guest today is Dr. Michelle Cherro, who is a second year child and adolescent psychiatry fellow at Mass General Hospital at this time. And the reason we invited her is because of the recent article that they published out of Lebanon discussing adolescent suicide risk in the country. Welcome, Michelle, to the podcast.
Thank you. Thank you for having me.
Michelle, before we start, can you introduce yourself and your work at AUB and in Boston?
Of course. So I actually did my psychiatry residency at AUB. I graduated 2 years ago. And so the article actually started working on while I was still a resident at AUB, and I worked on it with Dr. Fadi Maalouf, who's the current chairperson, Dr. Elie Ghossoub, who was my program director at the time, and my co-resident, Dr. Hala Itani. And then when I graduated, I moved on to continue my training as a child and adolescent psychiatry fellow at Mass General in Boston. And I'm supposed to graduate by the end of this year.
Excellent. Congratulations.
Thank you.
So can you tell people where this article was published and the title of the article?
Yeah, so this is an article published in PLOS One, and it's an open access article that anybody can go to. So it's entitled Predictors of Suicide Attempts Among Adolescents with Suicidal Ideations and a Plan. And it's from the NSDUH database.
Nice. So what motivated you and your team to study the predictors of suicide attempts among adolescents in Lebanon?
So the motivation really came from the gap that we see in Lebanon and the region. And the gap, I would say, even worldwide when it comes to this particular question. So suicide, as we know, among young people is a global health concern. But in Lebanon specifically, there's very little systematic research, especially when it comes to the most dangerous stage, which is when a teenager not only thinks about suicide, but actually makes a plan. And we know that not every young person with suicidal thoughts eventually attempts, but once a plan is in place, the risk is very, very high. Now, to be clear, our analysis used data from the United States, from the National Survey on Drug Use and Health, which is the NSDUH. But while the sample is American, the motivation was potentially Lebanese, and a lot of these risks are common and universal within adolescent processes. So hopefully it's to generate insights in suicide globally, but also more specifically for Lebanese youth.
Right, and we're going to ask this question in a bit, but I mean, yeah, suicide among adolescents is a global public health concern. And I think, as you said, I think it's hard when an adolescent says, I want to commit suicide, then it's hard sometimes to decide, like, are they saying the truth or not? But as you're saying, maybe if they have a plan, then the risk is much higher in that case. So how does Lebanon compare in terms of prevalence and risk of suicide attempts compared to the global population?
Yeah. So the issue with our data in Lebanon is that it's quite limited with what we know. But from some of the school-based surveys that are already in place, there are concerning rates. So there was actually a recent national survey published by Dadras et al. In 2023, and they found that about 13.5% of adolescents had considered suicide, and about 10% had made an attempt within the past year of the study. So these figures are comparable to global studies, and in some cases even higher than some places. But in Lebanon, they come on top of economic collapse, instability, conflict, wars, which can potentially amplify the risk even further.
Right. And as we discussed, your study used the NSDUH data from 2015, 2018. So why did you choose this data set, and how applicable is it to the Lebanese context?
Yeah, so the NSDUH is one of the very few large-scale surveys that we have that specifically asks adolescents not just about suicidal thoughts, but also about whether they had a plan and whether they attempted. So that level of detail is quite rare, and that's what allowed us to focus specifically on that transition from a plan to an attempt, which is really at the core of our study. So we had really enough adolescents, about 3,000 adolescents, which allows us to run meaningful statistical models. And without a data set of that size, it would have been quite difficult to identify the subtle predictors that we wanted to look into.
So now, this is a good segue into if you can walk us through the design of your study? And how did you select the adolescents with suicidal ideation and a plan? And what kind of analyses did you run?
Absolutely. So we pooled 4 years of the NSDUH data, so between 2015 and 2018. And we specifically looked at adolescents who answered yes to two questions. Have you had a suicidal thought within the past year? And have you had a suicide plan? So we specifically looked at those adolescents, and ages ranged from 12 to 17 years old. And then we examined among those adolescents who went on to report an attempt. We used both bivariate analyses first and then a multivariable logistic regression to really isolate independent predictors. And I know we'll talk a little bit more about the specific predictors that we found.
Yes, very interesting. It's going to be very interesting results that we'll discuss in a bit.
Mhm.
But I guess, which we discussed a while ago, but what makes studying the transition from having a plan to attempting suicide particularly important?
Yeah. So globally or overall, when we think about suicide risk, it's important to remember that not everyone who has suicidal thoughts goes on to attempt. In fact, research shows that only a third of people with suicidal ideation ever make an attempt. But when someone develops a concrete plan, we can think that the risk increases dramatically. And studies have actually shown that. So, a study from Germany found that 85% of adolescents with a suicide plan eventually attempt. So, the number is really quite high. And that tells us that the plan stage itself is a critical turning point. It's basically when the wish to die becomes more organized, more specific, and actionable. And even within that high risk group, not every single teenager makes an attempt, right? So there are still 15% that don't, per this German study. But so the key question is what makes the difference? What pushes some adolescents with a plan to take that extra step while others don't? And understanding those specific predictors, whether it's impulsivity, exposure to suicide, any other behavioral dysregulation, can help us intervene in that narrow but very crucial window.
Right. And also like understanding what the numbers in Lebanon are because they may not correlate with the numbers in Germany.
Absolutely. That's the issue, basically, because we don't have that very large data set in Lebanon to help us
Right.
understand the specific numbers. The somewhat good news is that a lot of these processes and predictors are universal to adolescent development. So understanding them even in a foreign data set can help us understand a little bit more, even if the numbers aren't quite the same.
Exactly. Because they can correlate somewhat with the numbers in other countries. Uh,
Absolutely.
so your study, what in terms of males and female prevalence
Mhm.
of suicide attempts, who was more prevalent in Lebanon, males or females?
Again, this is the NSDUH is for the US. Unfortunately, we didn't have the
Mhm.
Lebanese numbers, but in this particular database, we found that females were more likely to attempt than males, and that actually is quite consistent with what we see globally. What we know is that adolescent females are far more likely to report suicide attempts, and males are more likely to die by suicide, largely because they tend to use more lethal weapons. And for females, factors like potentially higher exposure to interpersonal stress, different patterns of coping may play a role. It's important to think about it this way, though. It doesn't mean that one group suffers more than the other. It just highlights that the risk can show up differently among across genders. So I would say clinically, the key message is that we should never underestimate risk in adolescent females with a suicide plan, and also recognize that there is a higher lethality among males.
Yeah, and I'm thinking about it like I have daughters myself, and I think also like maybe I don't know you can correct me if I'm wrong, but maybe also the interactions of adolescent girls among each other may be different than males. Like males, if they want to bully each other, they bully each other by like hitting each other, or it's like obvious to everyone. While females, it's more like you said, social interactions, all this other stuff. Do you think that plays a role into it?
Yeah, that's a good way of phrasing it, thinking about internalizing emotions versus externalizing behaviors. And what we do know is that the people or the patients or the youth who internalize more are at higher risk for depression, anxiety, suicidality. And among males, so it's I would think of it in two ways. One is that males who are potentially more aggressive, and we'll talk about that a little bit later, it's a more obvious cry for help, but at the same time, it could also signify higher risk. In females, even though the aggression, antisocial behaviors, and stuff like that may not be as prevalent, but the risk is still quite high and very important to notice, even in young females.
Right, exactly. Because it makes it even harder to notice. I think you have to notice it with males, probably they're more aggressive, so you notice it much easier in that case.
Absolutely.
And the other thing that you found, the interesting thing that you found is that antisocial behaviors, especially engaging in three or more antisocial behaviors, were strongly associated with attempts. What explains this connection?
Yeah, this I would say was the most interesting finding in this particular study. And there are different ways to think about why that is. First, I want to start by saying how we defined antisocial behaviors. And when we hear antisocial, the kind of immediate thought is somebody who's, how lacks empathy, and we're talking about antisocial personality disorder. But in this case, we were referring to rule-breaking behaviors and conduct behaviors like stealing, fighting, running away, carrying weapons, etc. So one way to think about this particular association is through impulsivity. So these behaviors that I mentioned, like the fighting, the stealing, etc., often reflect trouble with self-control and a tendency to act essentially without fully considering consequences. So if a young person who has an issue with impulsivity is already considering a suicide plan, that impulsivity makes it much easier for them to act in the heat of the moment. And another way, which is a very interesting way to think about it, is through what we call the ideation to action framework. And this was actually developed by Klonsky and May. And this model reminds that having suicidal thoughts or even a plan isn't enough for somebody to make an attempt, because most people are naturally held back by fear of death and low tolerance for pain. So for an attempt to occur, those specific barriers have to be lowered. So teens who are used to risky or aggressive behaviors, like the ones I mentioned, are often more familiar with pain, danger, conflict, and that exposure in particular may reduce their fear of death and make pain feel like less of a deterrent. So, to summarize the finding, when we see multiple antisocial behaviors, we may actually be seeing both of these forces at work: higher impulsivity and a weakening of those natural brakes that usually stop people from acting on suicidal thoughts.
Right. So basically, yeah, exactly. So impulsivity, and then you've already done risky behaviors, so you can do them much easier in that case.
Exactly,
Yeah.
exactly.
So the other one, which I think is not as surprising to me, is substance use and violent behaviors were also predictive. And I guess, can you expand on how these factors elevate suicide risk?
Yeah, so the findings are in one side of them is quite similar to the antisocial behaviors in explaining them through impulsivity. So whether it shows up as rule breaking or fighting or using substances, it continues to reflect that difficulty with self-control. But there is an added layer with substances. They don't just signal impulsivity, they actively lower inhibitions in the moment. And that's on a biological level. So we know that alcohol and many drugs suppress the prefrontal cortex, which is responsible for judgment, planning, impulse control. They can heighten reactivity in the limbic system, specifically the amygdala. So emotions like fear, anger, depression can feel more intense. And they can also disrupt serotonin and dopamine systems, which are key for regulating the mood. So together, all of these together, these changes in the brain can lower fear of death, blunt sensitivity to pain, impair problem solving, and increase negative emotions. So for a teenager with a suicide plan, this altered neurobiology can chip away at the natural protective barriers that would otherwise stop an attempt from happening.
Yes, basically what you're saying is one, they're impulsive because they're doing the substance abuse, but then the behavior itself leads to
Mhm.
changes in the brain that makes like impulsive or risky behaviors more common or more frequent.
Exactly. And this is a finding that we are aware of even in adult populations. The presence of substance use in the moment dramatically increases the risk of attempting suicide.
Right. So one thing that I always thought could be also a correlation is family dynamics and economic status.
Mhm.
What did you find on that front? The family dynamics example, divorce in the family, maybe domestic violence, stuff like that. So did you find any correlation with suicide attempts?
Yeah, so interestingly, in this particular database, once we adjusted for the behaviors that we mentioned in substance abuse, family and socioeconomic variables didn't emerge as independent predictors. But that's really about what this specific data set could capture. What we know from research is that family conflict, like you mentioned, low SES, financial stress, strongly influence depression and suicidal ideations in adolescents. But the finding that we have is that within this sample, once a young person already has a suicide plan, the factors that carried the most weight in predicting an attempt were the behavioral ones.
Right. Because what you're saying is, yes, depression, maybe anxiety, maybe suicidal ideations increase, but that does not necessarily transfer into a plan and then in a suicidal attempt. But this is
Exactly.
just based, and this is, I just want to tell viewers and listeners that this is just based on this data set. And
Exactly.
it's not like a be all and all.
Yes. Yes, absolutely. So like to simplify it, low SES, financial stress increase the risk of having suicidal thoughts, but not necessarily, like you said, translate into making an attempt. And
Right,
again, this is a very, like this data set that we chose is a very, very particular subpopulation of those who have suicidal thoughts.
right, right. So, I mean, you've done training in Lebanon, you've sort of practiced there, and you've trained with a lot of people who work there. What do these results, I guess, how should people in Lebanon, such as clinicians, schools, and families, interpret and deal with these results?
Yeah, so I would say the biggest red flags that we found when a teenager has a suicide plan, like we said, substance use, antisocial behavior, carry a lot of weight. So to start with clinicians, it would mean that assessment can't just stop at do you have suicidal thoughts and do you have a plan? It has to go further. They have to ask about behaviors, impulsive behaviors, risk-taking behaviors, and substance use, because these details can really tip us off to those who are at immediate risk. And for schools and family, it essentially means recognizing that these kinds of behaviors aren't just normal teenage rebellion. And a student who, for example, has been in multiple fights or is starting to experiment with drugs, especially if they've also mentioned suicide, is somebody who needs urgent support and safety planning. So, the key message I would say for people in Lebanon is that prevention starts with vigilance by asking directly about suicide, taking these risk behaviors seriously, and then knowing where to connect young people for help.
Right, exactly. Because also, a lot of times it's hard, especially in females, I guess, when they internalize their emotions, it's very hard to know what the plan is afterwards. Uh, and as we were talking, actually, an example came to my mind. My younger daughter is actually 13. And
Mhm.
last year, a couple of years ago, they had a girl in their class who was actually went to another school because she was very aggressive with all the kids. And then at
Mhm.
one point, she was aggressive with them. They saw her downtown, whatever. And then a couple of weeks later, she actually was able to get a gun and take her own life away.
Oh.
And I'm wondering whether this is an example of something that probably could have been recognized earlier because she was having aggressive behaviors with a lot of the other kids at the time.
Yes, that's a very unfortunate story, and
Right.
and I think there is a lot of stigma when it comes to kids who are aggressive and fight and get into trouble. So it kind of framing it in a way that these are teenagers who are struggling, not only acting out, can help us prevent things earlier. So yeah, it's a sad story,
Right.
and
Right.
hopefully what this study can do is kind of highlight the importance of recognizing that these behaviors are signaling a teenager who's really truly struggling could be at a higher risk.
Exactly. Because you don't want to like dismiss these kids and say, oh, this is a trouble kid. Let's
Mm.
dismiss them from the school or do this. You have to look deeper into why this kid is acting the way they are.
Absolutely, absolutely.
And so, were there any results that surprised you or contradicted your expectations?
Yeah, so I would say the most one of the most surprising one was actually the main finding. We were struck by how robustly antisocial behaviors predicted attempts. The other thing is we expected firearm related variables. There was a question about carrying handguns. We expected that variable to show up more strongly in terms of association. But the way that we framed it is because we're studying survivors of attempts. And unfortunately, like the example that you gave, firearm attempts often result in fatalities and may actually be underrepresented in this sample.
Right. So basically, what you're saying is maybe they weren't as frequent as you thought. But one thing we need to know is that a firearm attempt is probably going to lead to a successful suicidal attempt.
Correct, correct.
So, how are mental health services and public health policies in Lebanon currently targeting adolescents at risk, and what can they do to improve the recognition and targeting of these adolescents?
Yeah, so first of all, adolescents who have suicidal thoughts and have it combined with substance use or aggression may need a different kind of response than those who are just struggling with mood symptoms. So for Lebanon, it could mean developing services that don't just focus on depression, but can also integrate risk-taking and behavioral issues into suicide prevention programs. So one way to do that is to embed screening of these behaviors into existing systems in school health programs, primary care visits, like the pediatrician or the PCP. And another one is to build dedicated pathways for those adolescents where families need to know exactly where to turn if a teenager is suddenly using substances or engaging in violence. And at a policy level, investing in early intervention for substance use is very important because that directly reduces suicide risk. And on a cultural level, reducing stigma through campaigns that highlight suicide as a preventable issue and that seeking help is acceptable will make all of these services a lot more accessible.
Right. Which actually, you just got me to a good segue for my next question, which is are there societal or cultural factors in Lebanon that uniquely shape adolescent suicide risk compared to other countries? And how does the stigma affect suicide prevention efforts?
Yeah, absolutely. So Lebanese adolescents, as we know, are unfortunately growing up under pressures that go well beyond what we typically see in other contexts and in other countries. So if I want to kind of name a few, an ongoing economic crisis, a lot of political instability, displacement, war, and these aren't just background issues. They directly shape stress, family functioning, and a young person's sense of security about the future. On top of that, most of the services in mental health care that are specialized are centralized in Beirut. What this means is that young people outside of the capital often have little or no access to specialized mental health care. All of this really makes the landscape for suicide risk in Lebanon very distinct from other countries. And then if you add stigma to that, it compounds all of these challenges. Families often avoid talking about suicide, or they may minimize a teen's distress because of shame or fear of judgment or other reasons. And because of that, help seeking could be delayed until things reach a crisis. And that delay can be really critical because schools often end up the first and sometimes the only place where that risk is noticed, especially if it has to do with fighting or using substances, for example. But schools don't always have the tools or the training to respond. So that's why prevention in Lebanon not only needs to focus on expending resources like hotlines and clinics, but also changing the public conversations so that families and teens can feel safe asking for help early on before things reach a crisis.
Right, exactly. And I agree with you. I want to think about it. There's probably a lot of factors that can affect mental health in adolescents in Lebanon, but do you think there's maybe some positives in Lebanon, like family dynamics, stuff like that? Does that help, I guess? Or I don't know.
Yeah, absolutely. And this is where there are gaps in our understanding of those factors in this very particular landscape. So even though there are a lot of challenges, there could be a lot of protective factors for our youth, like you said, like family cohesion, potentially religious and cultural factors. The problem is we don't have a documented understanding of those protective factors. But one way to think about it is that suicide attempts as a whole aren't that different from global numbers. So even though we would expect catastrophic numbers in Lebanon, fortunately, that's still not the case. And a reason for that could be those protective factors that we don't have a very big understanding of yet.
Right, which means like we need to study what these factors are. So do you envision adapting this research into a Lebanon specific data set or intervention program?
Hopefully someday. I mean, that's the long-term vision, right? To develop a specific Lebanese data set that's large enough to really be able to understand these. And my hope is that this isn't a distant goal, but something hopefully we'll be able to put in place.
Sure, you can do it. So saying that, after what we discussed today, what role can parents, teachers, maybe, or peers play in recognizing warning signs and preventing suicide attempts? Because I think in this aspect, prevention and early recognition probably is key.
Yes, absolutely. So I would say the most important thing is to talk directly about suicide and ask directly about suicide, but also notice the factors that can often be dismissed, like we said, sudden aggression, substance use, legal disciplinary trouble, isolation. All of these need to be noticed. And once they have been, kind of knowing where to go to get the teenager help. So yeah, taking these specific behaviors very seriously and not saying these are normal teenage rebellion behaviors, I would say.
Right, because some of it crosses that line, and you cannot say it's normal.
Right.
So, what is the single most important takeaway for our listeners when it comes to adolescent suicide prevention worldwide, I guess, and particularly, I think, in Lebanon?
Yes. So I would say the single most important takeaway from this study is that when a teenager has a suicide plan, some of the biggest warning signs for attempting are substance use, repeated risk-taking behaviors, aggressive behaviors, and being female. So again, these aren't background issues. These are urgent red flags, and recognizing them early, again, by asking about suicide and connecting these young people can truly save lives. And I would say that despite, just to be a little bit hopeful, despite all of the challenges that Lebanon faces, we have the foundation to build stronger systems of support, and we already have a lot of excellent clinicians who can provide that care.
Right, right. Yeah, because there's also like the excellent clinicians, and there is, correct me if I'm wrong, there's also a suicide hotline, right, in Lebanon?
Correct. Yes, the Embrace Suicide Hotline.
Right, right. And it's been there for a long time, even before the crisis.
Yes, and this is a 24/7 service that's anonymous, so it's accessible to everyone.
Yep. And it is run by like in NGO, right? It's not non-governmental. Because in Lebanon, I think there's a lot of like individual or group efforts outside of the government.
Correct. Like institutions, NGOs,
Right.
these kinds of community clinics that are popping up. So yeah.
Right. And where can people learn more about your work or find resources if they're concerned about a young person at risk?
Yes, so our full study is published in PLOS One, as I mentioned, so anybody can read it. It's open access. And just again to mention my co-authors, Drs. Fadi Maalouf, Elie Ghossoub, and Hala Itani. And in terms of resources, for families in Lebanon, one of the biggest resources is, I would say, Embrace. Like we said, and the hotline is 1564. They offer immediate and confidential support. And not to forget the institution. So I'll give AUBMC, where I trained for 5 years, as a biggest example. So the clinicians are excellent, psychiatrists, psychologists. And the nice thing is that there is an outpatient clinic that offers low-fee care. And this one is delivered by the residents and under direct supervision of the attendings. And this makes the financial burden easier for a lot of families who don't otherwise have access. And there are plenty of other institutions, university institutions and community clinics and NGOs in Lebanon. All of those are accessible online. And internationally, I would say there's the WHO, who offers resources on their website for families and teenagers. And maybe just to close on a hopeful note, the risks that we've discussed are very real, but Lebanon already, like we said, has committed clinicians, community organizations, and family who care deeply about young people. And hopefully, by building on what we have already and continuing to talk openly about suicide, I think we can create a safer future for adolescents in Lebanon.
Right. Michelle, thank you for being on this podcast. And I totally agree with you that in Lebanon, I think mental health is not as much of a taboo anymore. And that's thanks to clinicians like you and the people at AUB and other institutions who have been able to push mental health to the forefront and to be recognized early. Thank you very much.
Thank you for having me.